Welcome to the Supported Living Property Podcast with your host, me, Lisa Brown, the place to learn about supported living property investing. Hi, Sarah. It's great to have you here today. How are you doing?
Hi, Lisa. It's great to be here. Thanks for the invitation. No, I'm well, thank you.
Good. For people who don't know you, do you want to introduce yourself and tell people a little bit about you?
Thank you. Yes. So my name's Sarah Davis and I'm Policy and Practice Officer working for the Chartered Institute of Housing. So the Chartered Institute of Housing is the professional body for the people, the individuals who work in the housing sector, predominantly the social housing sector. So our members will work for local authorities, for housing associations, for charities. We also have academics, consultants. We have some tenants as our members as well. So that kind of commitment to the housing sector and working within it, those are our members.
And it's really important work, isn't it, that you guys do? And I think it's often something and people aren't terribly sure about what it is that you do. So it's useful to know. I know some listeners will be members already and will be really, really very used to the work that you're doing. But you're looking at doing, and obviously with your role particularly, some really interesting research around housing and the impact of housing. And we'll talk about the work that you're doing. You can tell it far better than I can. So tell us a little bit about that.
So my background before I worked for CIH was with housing associations and a local authority, but I particularly worked with older people. So when I was working with the local authority, we were doing a lot of work to refurbish our sheltered schemes. So I was involved in steering the project through that. And I also worked for a specialist for older people. So my background's always been around that sort of specialist housing sector in particular, and obviously what you see with that is the importance of housing as the foundation for people's living well and good health, and that really it's basically the foundation upon which people can build their lives. So good and decent housing is really important, and obviously we've seen that underlined significantly during the pandemic, where people's home life and living experience, because they were there so much more, if they were in poor conditions, you saw the impact of that, with overcrowding, meaning that the COVID could spread more rapidly in those kind of settings, etc. And we've also, in a negative way, seen the impact of poor housing on people's health, and obviously with the really tragic case of Awar Bishak. So housing in the social housing sector, I think people have always been very aware that what they do is more than provide a really good home, but when they provide a really good home, it has an impact that's a benefit for people's life and well-being and for communities. And so I've always had that sort of hat within CIH of, well, how do we join up housing with health and with social care so that we can maximise the benefits for what is usually a shared constituency, a shared kind of group of people that we have that interest in, because for social housing often they have people living there who have long-term health conditions. There is obviously a higher proportion of people, disabled people living in the social sector than in owner occupation, because of the issues around accessing employment and income. And so often those people overlap with those that local authorities may be interacting with for care needs, or the health with, multiple health conditions. So there's really an important, and you see it particularly, I suppose, at the specialist housing end clearly, but it's there across housing, that actually if you can get the housing right and connect with services, you actually can help your partner agencies get messages in and helping, and you can actually help your tenants thrive. And by providing a good home, that's a foundation, as I say. So for us at CIH, the kind of housing, health and care overlap has always been an important one. And what we try and do is develop tools to help housing providers understand how to connect with health and with social care. And some of the work we've been doing more recently has been following a partnership in the east of England between housing associations and public health across 3 local authorities. and looking at work they're doing together to try and do exactly that, bring services together to benefit that shared constituency of people so that they can thrive. So that's the work we're following in the east of England, that we've written up in 2 papers so far, sharing the art of the possible about developing partnerships, and then expanding the art of the possible, looking at how the new integrated care systems might help foster that kind of partnership approach.
So it sounds really basic. It almost sounds like it's something that should just be happening automatically everywhere. That, you know, of course it makes sense that housing and health and care all interact with each other. But they don't, do they? In reality, these different organisations work in different silos, don't they?
They do. And when you think about the origins, particularly of social housing and public housing interventions, came out of health, out of a drive to improve health, to deal with slum clearance, etc. So it should be part of the DNA and seem an easy connection, but actually it really isn't, because both sectors are quite fragmented for each other. So it can be unclear about the best ways to enter those partnerships. Really, how do you do it? And so for housing, health seems like a big beast, and you know, how do you navigate it and who do you talk to? But equally, because the housing sector is lots of players, some very big national players, but also some very small discrete players in localities, how do health people interact across the board with what are kind of, you know, fragmented individual groups? So that's the challenge for both sectors, and for local authorities it's sort of in the middle, and where you've got 2-tier there, you've got multiple players in the local authority sector as well, is actually learning each other's structures and knowing how to navigate. And that's why very often partnerships start with people who connect and get each other's contribution, and why it's still very much driven by, you know, those individuals who can make the connection and have the influence within their organizations, or the ability to convene partners, and very often that's where you see it starts to work. But from the housing perspective, you see partnerships starting around identifying needs within health. So a lot of examples come from, particularly maybe the supported and older people sector, recognizing that health had issues around delayed transfer of care, for example, and how might retirement housing or extra care housing offer step up, step down and rehabilitation within a housing setting that might be more successful. So some partnerships started up there, some partnerships started up around, you know, A&E, recognizing that, you know, homeless people are very often presenting in A&E, and, you know, maybe there were ways to actually help them by connecting through the housing field and trying to get them housed, and, you know, so. And then we have the example in the east of England with Bedfordshire, Milton Keynes and Central Bedfordshire, working with Grand Union Housing and with Peabody, and they came together around an estate where there were lots of problems around drug and alcohol. They were doing regeneration work, they were trying to tackle antisocial behaviour, and then they recognised a lot of people needed support around mental health and addictions. So, you know, and it became a bit more of a public health message and preventative message in there. So there are multiple ways that you try and engage. The trick is, and the thing that's always difficult, is how then do you grow that and scale that up so that those partnerships actually get embedded and not just dependent on a person who might move on, you know, but actually how do we embed that in these systems?
Absolutely, because like you say, you get the 2 people working together from 2 different organisations, someone leaves, and that then changes, doesn't it? You know, and it sounds like some really innovative stuff that's been going on, some really creative thinking. Certainly with, you know, my background was as an emergency nurse and an emergency sister, and we would always see the same people in night after night. And so being able to have somewhere that you could actually talk to work creatively to stop that and help that person better sounds like a really good thing.
Yes.
You know, so that had quite good outcomes, did it, that homelessness project?
The examples are sometimes quite difficult, because as you'll know with your health background, if you that very often the pressure on resources is such that if they start something as a pilot, no matter how effective it seems as a pilot, the problem is that, you know, sustaining it long term. So there have been some really good examples, but obviously one of the issues around placing, so for example, placing housing people within a hospital around discharge or within an A&E, the issue is always around finding the right place and building the relationship of trust. If it's someone who's been homeless for a long time, enabling them to take up that support. But there have been examples where it's been sustained, yes. But one of the other issues you do have is, no matter how much kind of like money you save health, they've always got somewhere else to spend it. So actually, you know, how do we make some pilots self-sustaining and how do you keep it going is a real challenge. And the challenge for the housing sector is, as you'll know yourself, supported housing can be really hard to make work, really hard to continue in terms of viability of services, particularly around that, where the funding comes for the support element, which is fundamental to supported housing.
Of course.
And that's a really difficult one. So, you know, it's a very difficult one to keep sustaining. And then also, how do you enable people, once they've been in the supported housing field, to move on, because we have that crisis of shortage of housing. So there are some real challenges around it, but yet there are examples where things have worked. There are examples where they're trying to expand the partnership and make it, you know, actually get in there before sort of crisis, and just build the relationships of trust that mean actually they'll start to take risks with each other and build services.
And that's hard for anyone in the current climate, isn't it, to take any risks while budgets are so tight? I think there's so much pressure on people, isn't there? Absolutely. Yes. There was also some work around disabled facilities grant, wasn't there? This is the grant that's available for adaptations to properties for people. And I think a lot of people would assume that already was a kind of collaboration between housing and health and care that was involved in disabled facilities grants. What was the work around that?
So disabled facilities grant, of course, now sits in the Better Care Fund, and I think there was a lot of positivity from the perspective of housing and local authorities around this enabling a bigger partnership. But I think and it has worked to a certain degree, but it is very focused, has become very focused around the hospital discharge pressures, which you can understand. But I think the thing with disabled facilities grant is to make the most of them, is to understand that they have to be, you know, they have to be targeted at a much earlier threshold. And I think there are some really good examples where local authorities have worked with health around understanding that and getting a smoother, streamlined approach. But there are still times when it really you have to kind of like jump through hoops, and it's still the thing with disabled facilities grants, I think, is you'll always find you can spend it and more, because it's never, you know, we have stock that really just needs a lot of adaptations. Old stock, we have some that won't be improved, but yes, so disabled facilities grants for some has been able to be a lever of how you use it creatively in the partnerships with the Better Care Fund, but it not entirely always is. Sometimes it is just very focused around, we have so many pressures to actually discharge people that's where the focus is, and if you're not careful, that means you're going in at a crisis point. Now, still very valid, because it actually does mean people can be discharged to be at home safely where they want to be, but actually the benefit for if with disabled facilities is to identify people at the early stage and get it in there earlier on, you know, so not waiting until they meet a social care threshold, for example, but actually earlier, to enable them to live a bit more successfully and independently. And there have been some really good examples of that. And I think when we a few years ago had a lot more home improvement agencies, and some of that again has retreated because of a loss of funding, but they're really where they still thrive. They're really good at that. And we also saw it come up again in the Adult Social Care Reform White Paper, where government committed to ongoing funding of the Disabled Facilities Grant, and also flagged up that they wanted to invest in some rapid response. I would say it was a rapid response, kind of what the previous handyman service used to be, or handy person service, you know, that going in there and doing small repairs and small adaptations to enable people to be safe, to be able to people discharged really quickly where maybe they didn't need a big adaptation, or whilst they were waiting for a bigger adaptation. So it's that kind of trying to be fleet of foot with disabled facilities grant, which is, you know, how do you learn from places that have managed to do that, and improve and streamline your service. So that's a key area for partnership, but it doesn't always, the funding hasn't always been followed by that effective partnership, if you see what I mean. Sometimes it has and sometimes it hasn't. So yeah, it's a mixed picture, I would say, in terms of how well that's kind of brokered some of the relationships.
Yeah, and you know, it is really important, isn't it, to get right, like you say. It prevents people being admitted to hospital, gets people home quicker, and being able to work in a timely manner is really key, isn't it? Because actually, what we've seen historically is someone who needed some adaptations doing to a property and it not being done for 18 months, 2 years,
Yes.
because of waiting lists, and that's obviously so people are stuck in inappropriate, unsafe homes, you know.
Yes,
just really not
and
safe.
That's where the kind of more of a rapid response you know, actually can make things safe whilst they're waiting for some. So if they're waiting for a big adaptation, like a level access shower, but if they have internal stairs, for example, some of the rapid response in terms of putting in extra banisters or extra grab rails can make things a bit safer for them whilst they're waiting for that. And for some, maybe just what they need, you know, actually that help getting down those stairs more safely, or any internal steps, because we know that falls is a big issue for older people, and a big, you know, obviously has a big impact for the health service if older people fall, for example. So it's about the third biggest kind of cost, isn't it, really, after cold and damp in homes.
Yeah,
so, yeah.
And massive impacts for the individuals living there.
Absolutely,
as well.
yeah.
You end up with a
Huge.
broken hip, the impact of that is
absolutely, it's huge. And also, just some of those adaptations mean people, although it might take them longer, can actually then continue to, you know, safely carry out daily acts of living, like washing themselves or cooking, without the help needed from formal or informal care. You know, it can help people sustain their kind of dignity. Or if they do need care, it means people can come in and care for them safely as well. So, you know, actually the home and making sure that environment is right is a benefit for the individuals, but also as care needs might escalate, that people can care for them safely as well. So it's really important. Having the right kind of home is crucial for that. And that's thinking about new build. That's why CIH is part of the alliance that's called for all new homes to be built to a higher accessibility and adaptable standard, which government has committed to. So we're keen to see that happen soon. You know, they have some technical consultation to take place, but all new homes should be built to that higher standard, which means that if you do have to adapt, you can do it more quickly, easily, without some of the cost. So it's all about, you know, maintaining that safety.
Yeah, it's really key, isn't it? Because like you say, we've got so much old housing stock that is unsafe and isn't or just not necessarily, it's just not appropriate if you have any accessibility needs at all. So going back to the research a little bit, obviously there was lots of learnings from this collaboration and working together. What does that mean going forward? What's the sort of impact of that, and what are the lessons to be sort of taken forward, do you think?
So the partnership started with key people that got it, as I say. So the partnership started with public health recognizing that they needed that some of their key messages and the key groups that of the community they wanted to reach were in social areas with social housing. And so they took on board someone who understood health but had a housing background. And there were a couple of housing organisations who had people, including the chief exec of Grand Union, Aileen, who understood health and really wanted to see that what they contributed to in their communities, you know, had that bigger impact to enable people to thrive. So those partnerships started from those people connecting. But what they have then done is that, so for example, some of the housing partners have invested in the public health role, so that they've got someone there to focus on building those relationships for a period of time. And what's come from that is understanding that overlap of the people we need to reach are here. This social housing landlord or these social housing landlords can help us, you know, actually get public health messages in, help us to support people and identify what help is needed. So so for example, during the pandemic, the housing providers were often the people who took in the messages to communities who might have been a bit vaccine reluctant. And when public health then went into those areas, they found that the housing providers has already kind of laid the ground around good messages around vaccination, for example. So that, you know, those kind of like connections of, you know, how do we approach people? What do we need to tell them about public health messages? This is the training, these are the resources that public health can give you. Enable the housing workers to be confident in putting those messages in. So that was the vaccine example. They've also done it around training around the benefits of stopping smoking, you know, around obesity and exercise. And obviously for a housing provider, it can be like, well, how do I broach things like that? And if I broach things, well, what kind of support might my tenants get? Our tenants get, you know, from public health. So what they've been able to do is connect and train housing staff and how to approach people talking about stopping smoking, for example, enabling them to be able to make referrals to programs that help people stop smoking. And recognise for the housing organisation the benefit of investing time of their workers in that is that people who stop smoking will be healthier, will have more income, so issues around arrears might be addressed. Won't have to necessarily make the same kind of investment in voids. So actually that pre-investment in enabling their staff to have this as part of their role as they engage with communities benefits the housing organisation, benefits its health partner, benefits their tenants as well, because very often people do want to give up smoking, but actually where do they, you know, they don't always know where to get the support, and so that kind of like becomes a bit of a virtuous circle where everyone benefits.
And you've got the issue of where the housing staff are in that property, perhaps, and accessing those tenants in a way that perhaps those tenants aren't accessing health services and aren't accessing. Yeah, absolutely.
And often a relationship of trust as well, being able to be built up, because they are, as you say, more likely to be going into those properties more often. So, you know, they can have the time to build up those relationships that enable them to, you know, to broach things that for tenants and, you know, just to support them.
Do you see this as something that's going to be rolled out into other areas? Do you see that's where this is going?
So that's a practical example of how the partnership works. But I do think the example of how the partnership operates is rolling out. So one of the things that they've done is enabled that connection between the public health. There's a small team in public health now focused around the built environment and social housing, and that team kind of works closely with and convenes connections with the housing providers, so two big local players and smaller ones as well, and they can tailor how they work together around what the needs of an identified community is. So one organisation has done a lot of work, as I say, around smoking cessation. Grand Union and Public Health have worked a lot around one estate around tackling mental health and addictions, that's also then addressed issues like antisocial behaviour, and has really built that community up. And the organisation was also going in and doing some physical regeneration, so that community has benefited all round. So those are the examples of how they work out, but it's about how you convene the partnership. And one of the things that this partnership has shown is a bit like housing's sort of more getting its act together about collaborating and working with public health. And we have seen another area in Worcestershire where chief execs of several housing organisations are doing the same, because obviously it's as I said, housing there's lots of players, and you know, a lot of people listening to you will be small players in a local area. Well, how do they connect with a big, a big beast like public health or, the local NHS trust. And it's actually about how housing itself gets itself together and provides a platform so that it makes it easy for health to talk to housing, and it gets kind of distributed around housing. So there is another area where they've tried that model where housing has collectively got together, and they have a designated chief exec who often goes to all of the health partnerships. So, and will probably be the voice in the integrated care partnership as it develops. So, it's actually getting that together. And for a lot of, that's hard with housing associations. So for a lot of smaller, where there might be a very small charity doing it, actually it is about finding the way in that might actually be on the tailcoats of, that bigger partnership. So I think there's a real challenge for smaller providers that perhaps listen to you a lot and take up a lot of what you offer. It's actually, thinking about how you might, where's the forum where you might actually be able to be a voice in that, because you won't have the capacity to necessarily do it yourself. And I do think there's a challenge to housing to make it easy for health, to make it easy for how you get into those integrated partnerships. Excuse me.
It sounds really, it's such important work, isn't it? But like you say, it's just getting everyone talking to each other in the right way so that it is an effective use of everyone's time, I guess, and translation of that message in the right way to get it down to tenants. Thank you, Sarah. It's been really, really helpful and really interesting hearing about this work. We'll put links to the documents in the show notes, and contact details and stuff will all be there. So if people want to find out more, they can go and read those there. But thank you for taking the time to talk to us today.
No, it was great. Thank you. I love talking about this. So it's been really a pleasure to do so. Thank you.
Thank you. Goodbye.
Okay. Bye-bye.